Our next presenter, the penultimate presentation, is from Fekade Sime, and he's going to tell us about the stability of ceftazidime avibactam for use in OPAT, which is an extension of the presentation from Mark Gilchrist earlier. Thank you, Fekade.
Thanks, Jason. So a couple of disclosures before I begin. So first, I'm trying to step in for Sime Naka, who has not been able to come with us for reasons beyond her capacity. And this work has been supported by Pfizer's Global Medical Grant Program as an investigator-initiated research grant. So we did this research just to support the clinical interest of using ceftazidime avibactam in outpatient parenteral antimicrobial therapy program. So data for this drug was scarce because it was a relatively new drug. So the first mention of interest or use of ceftazidime avibactam in OPAT is from a Spanish group. It was published in a case report that's displayed here on the slides. So they used it for the treatment of multi-drug resistant Klebsiella pneumonia bacteremia in a patient with acute myeloblastic leukemia. And the isolate was typically resistant to carbapenems and even to colistin. And only ceftazidime avibactam was active against this isolate. So they initiated treatment with ceftazidime avibactam, and the patient was stable. So they decided to enroll this patient in their hospital at home program. But unfortunately, because I think there was not enough data on the stability of this new drug, they had to enroll him in OPAT program in multiple daily dosing regimen, and the nurses had to visit this patient twice daily, which is not, as you would imagine, which is not convenient to run. So the first mention of the traditional solution for this kind of scenarios is to use the total daily dose as a continuous infusion. This is often practiced for most other beta-lactams where there is stability data. The first mention of continuous use of this new agent in OPAT is for another group in Europe from Belgium. So they used it in sort of off-label use without stability data being available in 10 patients again infected with a multi-drug resistant bug. So they used relatively larger dose, 5 gram infused every 12 hours, combined with therapeutic drug monitoring to achieve high target against the multi-resistant bug they were targeting to treat. So the patients, 54% of patients had MDR Pseudomonas aeruginosa, and the rest had MDR-K pneumonia. So that's why they were targeting a very high level exposure. Aaron was just describing in his talk recently. So they were pretty much successful in terms of clinical cure and microbiological eradication, even though the patient size, the sample size is small, so 30-day mortality was also low. It appeared to be effective. The target attainment in terms of PK/PD, target attainment in the plasma was also effective, 100% target attainment. But the wider practice of this in other settings was limited because of the lack of data on the stability of avibactam and ceftazidime for continuous infusion, and particularly because of concerns of pyridine toxicity, which is pyridine is one of the degradation products of ceftazidime. So the first, I think Mark has presented this slide previously, so I will not dwell much on this. So the first available data on continuous infusion of ceftazidime alone is from the BSAC drug stability program, and they were able to demonstrate that 12-hourly infusion is possible as long as we do not store ceftazidime longer than 2 days in fridge. So in OPAT, they do sequential. We do sequential stability testing because the drugs are kept in the fridge, and then they are exposed to in-use temperatures that go up to 32 degrees, close to the body temperature as well. So this data effectively shows stability for 12-hourly infusions, and the limit of pyridine exposure is a bit debatable in the literature. So the monograph limits are inconsistent from one monograph to the other, but based on the interpretation of the BSAC stability working group, it was able to meet their their target, which was 30 milligram per device for the P monograph limit of 0.5% weight by weight. So it was okay as well. But data on avibactam stability was lacking, so that was one of the limitations that we tried to fill in with this project. So we did a stability study for both ceftazidime and avibactam all together into elastomeric infusion devices. Those diffuser device we use locally, and the easy pump device, which is used locally as well and elsewhere in Europe as well, which is commonly used. So our data was reassuring. So it's pretty much consistent in terms of ceftazidime stability compared to the data from the BISAC working group. So we did test at 3 different concentrations, and the results are pretty much similar. So we tried to do some regression-based simulations as well, so consistent with the observation from the BISAC data. So as long as we store the infuses for not longer than 72 hours prior to the in-use temperature exposure at 32 degrees Celsius, we can achieve at least 70%, 90% stability target for 12-hourly infusions. So the results for avibactam are also similar. Avibactam seems to be relatively better in terms of stability compared to ceftazidime, but more or less the results are the same. So we need to keep the devices for not longer than 72 hours in the fridge prior to in-use temperature exposure for 12-hourly infusions. The biggest controversy, again, which I guess needs to be answered in the future, is with regards to pyridine accumulation, whether the amount of pyridine that accumulates during degradation of ceftazidime is clinically safe or not. So we were able to estimate that in the 2 devices up to 76 or close to 80 milligram of pyridine may be generated and administered or delivered to the patient. But whether this amount is safe or not, whether there is no adequate data from the literature. So the monograph limits for this are inconsistent. For example, so the USP has got a 0.4% weight by weight limit when formulated together with sodium carbonate, but in products containing arginine, it has 0.3 weight by weight limit. BP has 0.5 weight by weight limit. And in both USP and EMA guidelines, the total daily limit of exposure is about 2 milligram when pyridine is used as an excipient in pharmaceutical formulations. So the actual toxic level of pyridine is not known from animal model data. So no observed adverse effect level was reported to be 1 milligram per kilogram per day, but this is equivalent to like 70 milligrams in a person of 70 kg. So perhaps how this translates into a clinical setting needs to be further studied in the future. So in conclusions, so 12-hourly infusion where less than 10% degradation is acceptable is possible. So, and prolonged fridge storage for greater than 72 hours should be avoided because the sequential stability would not meet at least 90% target limit. And based on the current monograph limits, pyridine generated exceeds all monograph limits, but the general clinical understanding is the amount generated is acceptable even though there is no data regarding its safety. So, thank you.
Thanks, Fekade. That's one of the trickiest questions in OPAT stability that you and your team have been able to study, and you made a really great contribution. Thank you very much.